let's start with a definition first. Hernias occur essentially when the intra-abdominal contents move through a defect in or around the abdomen to create a lump. There are various types of hernias, some more common than others. The more common ones being in the groin, so-called inguinal and femoral hernias. Another common hernia can occur around the belly button, so-called paraumbilical hernia. Also, you can get hernias through old surgical scars, and these are aptly named incisional hernias. There are rarer types of hernias, but perhaps that's a discussion for another day. A hernia happens when intra-abdominal contents, and they can be bowel, fat or an organ, protrude through a defect in the abdominal wall. Sometimes these defects can be congenital or inherent, or actually akin to a design defect, and other times those defects can be acquired. An example of that is through an old surgical incision site. Some of the more common hernias, including inguinal or groin hernias, occur because, particularly in men, there are inherent congenital weaknesses within the groin. These weaknesses are actually left over from the descent of the testicle, which has to journey from inside the abdomen to essentially outside of the body by the time you are one, and they leave these little holes in the groin through which hernias can develop. The only real option today is unfortunately surgery. The real question is, when do you operate? And that's an interesting one. I think most people would agree that if the hernia, wherever it is very big, or is very painful, or is getting in the way with work or daily activities, it should be repaired. The debate exists around the smaller, less symptomatic, less painful hernias. But that said, the debate really only exists, to be fair, in the UK. Around the world, including North, South America, Europe, Antipodes, Far East, etc., the general consensus, even in these small hernias, particularly the inguinal hernias, they should be repaired. Because if you don't repair them, with time, they tend to get bigger. The bigger they get, the more complex they are to repair eventually, and the more likelihood of something going wrong. And although it's a small risk, there is a risk of strangulation, and that's where the contents of the hernia can lose their blood supply very suddenly, and in some cases that can be extremely serious and even fatal if not acted upon immediately. In the UK, we are performing fewer, particularly groin hernia surgeries in the NHS, and this I think is unfortunate. Hernias, again, particularly groin hernias, have found themselves onto these so-called low priority lists or of limited clinical effectiveness lists, and therefore are not being commissioned by the clinical commissioning groups. I think this is a mistake, and the Royal College of Surgeons have put out a position statement saying that this really should not continue. There is now a parliamentary working group which is looking into this, as is the Action for Campaign on Hernias, which will hopefully try and reverse these decisions. It's also interesting that the World Health Organization backs up the view of the rest of the world that even in small asymptomatic hernias, if the patient is young and fit and active, they should be repaired. Laparoscopic, or to give it another term, keyhole surgery, which tends to use a few small incisions, can be used very effectively in certain hernias. Certain hernias lend themselves particularly well to keyhole treatment, and I would say that the groin, inguinal and femoral hernias fall into that line. Incisional hernias have to be treated on a more bespoke basis. Some are suitable for keyhole surgery, but some, especially the larger ones, probably are not. Belly button or paraumbilical hernias, because they're small, are probably not best treated by keyhole surgery, as the advantages are not that great. Keyhole or laparoscopic surgery particularly lends itself to groin hernia repair, and certainly in my practice I do 90% of my groin hernias using the keyhole method today. The keyhole method confers a number of very significant advantages. Firstly, as you would expect, the pain is less intense and of shorter duration, and people generally recover in a shorter period of time. To give you some examples, for a keyhole operation, most of my patients tend to be pain-free by the end of the first week, and back to work within a week, possibly two, They're certainly driving, most of them within 2 to 3 days, and back to full activity in 2 weeks. With open surgery, that's a single larger cut actually in the groin, then you can probably double or sometimes even triple those time frames. Another advantage of groin keyhole surgery is that we can routinely look at the other side. Now, that's not something you can do in open surgery. You wouldn't make a cut just to have a look. But in about 10% of people, we recognise that they are going to develop a hernia on that side, and we can do something about it. And in fact, that makes no difference to the patient's recovery. The final advantage, and I think for me personally, this is probably the biggest one, is that after groin hernia surgery, one of the complications is long-term chronic groin pain. Now, this doesn't always have to be debilitating, but it certainly can be a nuisance, and people do complain about it. We quote for open surgery, more traditional surgery, about 4 to 10% risk. With keyhole surgery, it's less than 1%. I have performed personally over 1,500 keyhole groin hernia operations, and I've seen chronic groin pain in about 3, possibly 4 patients, so it really is much lower incidence. Laparoscopic surgery is not always best used in groin hernia surgery, and this applies particularly to the elderly or frail. And the reason for that is because you need a general anaesthetic to successfully complete a laparoscopic operation. Whereas with an open inguinal hernia repair, you can safely do that under local anaesthetic. So if the patient isn't fit for general anaesthetic, then maybe an open repair is better for them.